Hi, everyone. I want to welcome you to our webinar. This is Rachel Tabak from Washington University in St. Louis. We have two really great speakers for our webinar today that are going to talk about some interesting projects. I want to tell you first that this is brought to you by the SIG Implementation and Sustainability, Scalability. And I want to thank ISBNPA for hosting this webinar today. So our first speaker is going to be Dr. Taren Swindle from University of Arkansas Medical Sciences. She's an assistant professor of family and preventive medicine, and she's an expert in obesity factors in childcare and home settings. She's going to talk particularly about her work in childcare and the intervention that she helped develop called WISE, Together We Inspire Smart Eating, developed for children under 7, and it's demonstrated an impact, and she's going to talk about how to get this intervention implemented in childcare settings. And then we're also going to have Dr. Yoong from, if I get this right, University of Newcastle. She's a fellow there. She's in the Schools of Public Health and Medicine. She's also a dietitian, so close to my heart. She studies implementation of guidelines, and she's going to talk specifically today about nutrition guidelines and how to get those implemented in childcare. And she's going to talk through a research agenda on moving to a technological approach to do that with something called Feed Australia to help childcare practitioners be able to better implement those guidelines. I think don't want to spoil anyone's presentation, so I'll go ahead and have us get started. Just before we do, if you do have questions throughout the webinar, I think everyone is not able to speak, but there is a Q&A box that you should be able to type questions into, and we will read and ask our presenters to answer those questions. So feel free to do that throughout, and there'll be a question and answer section at the end after both of our speakers have presented. So I think I'm going to turn it over to Taren.
Great. Thank you so much, Rachel. Can you hear me okay?
Yep.
Great.
I can.
Okay. Well, we'll go ahead and get started. I really appreciate that introduction. Before I go further, I have to figure out how to advance the slides. Oh, there we are. I've got it. Okay, so I want to start by providing my funding and financial disclosures to you all. And then start by telling you a little bit about where I'm going to go today. First, I'm going to be speaking about a formative evaluation that we did related to the implementation of WISE. Then I'll be talking about a stakeholder engagement process for how we use the information from our formative evaluation to arrive at an implementation strategy. And then I'll be talking about the trial that we're running now, which is a hybrid TAP 3 designed to compare a basic implementation approach to an enhanced implementation approach. So as she said, WISE is the thing or the innovation that we do. And WISE is intended for delivery across an entire school year. So there are 8 fruit and vegetable units, each that last a month, and each that progress through the same type of lessons across the month. So for example, they start with sensory exploration, and then they progress to simple low-cost recipes. This is implemented by the early childhood educators, so they are doing it themselves in their classrooms. Now, WISE has a few key practices that are evidence-based. These are the things that we cover in our training, and we ask educators to do as they implement WISE. We want them to use a mascot. Her name is Wendy Wise. She's an owl puppet. She travels between the barn and the school to deliver updates on the farm, and she really is a positive cheerleader and encourager for healthy habits and for the target foods. We want them to role model, to eat the food with the children, and to make positive comments about those foods. We want them to provide the exposures in a hands-on way, like these children are demonstrating for us. It's not a cooking style type of a program. The children should be having those types of interactions with the food. And then we want them to use positive feeding practices at WISE lessons and at meals, because we know that kids react negatively when they're pressured to eat foods. And then in turn, they also respond positively when they're given skills to attune to their own hunger and satiety. So we found out in a previous implementation of this study that was funded by the USDA that our basic kind of standard approaches to implementation don't quite get us there for the kinds of fidelity outcomes that we want. So what I mean by that is, the standard way that we do things in childcare is we train and then we set them free to do what they do. And this kind of train and pray approach led to suboptimal implementation. We saw between 20 and 50% uptake of our evidence-based practices. So why is that? Why do or don't educators use those evidence-based practices? We wanted to understand barriers and facilitators to that. So we leveraged data from that USDA study to inform this study, because as I mentioned, we left that study with questions. What's going on? Why do some teachers do well and others struggle so much? And so we were able to take that data and identify people along a spectrum, which I'll speak about, to sample them for our qualitative interviews. So we had 49 classrooms worth of fidelity data. All of those were rated on our evidence-based practices on a scale of 0 to 4. If they had an average of 3 or better, those were identified as positive deviance. And if they had an average of 2 or fewer, those were identified as negative deviance. And so across all of the practices, we had 24 people that were failing to meet fidelity. They were negatively deviant. And we were able to recruit 10 of those for our interviews. It was far more rare to have folks achieving fidelity across all of the practices. That only happened in 3 instances, and we were able to recruit 2 of those. Now, there were some people left in the middle, more of a mix, and so that's what we went after next, so that we could get some of those teachers who were doing well with a couple things maybe, but still struggling in some of our other evidence-based practices. And with this sample, we used the IPERS framework to inform our interview guides and also the analysis of the data that we collected. Now, the results that we got out of this process are more than I can present to you today. We identified over 75 unique barriers and facilitators. That's more than we can attune to. But I wanted to highlight a few. Role modeling, for example, it's a real barrier if the teacher does not like the food and can't fake eating the food with the children. Counter to that, a facilitator for using the Mascot, for example, if she believes it works, if she's seen it with her eyes, if she's convinced that using the Mascot matters. Now, we also observed contextual factors that teachers talked about in these interviews that could act as both barriers and facilitators. So if a program had a lot of other competing initiatives and programs at their center, they had a harder time uptaking some of our practices. They also really talked a lot about director and leadership support and how that impacted them either positively or negatively. So with that many barriers and facilitators, how do we prioritize our information? And then what strategies did we select? We did this through partnership with stakeholders. I'd like to introduce you to our Stakeholder Panel. It's a wonderful group of individuals that consists of lead teachers, assistant teachers, directors, a cook, and a parent. And they provided us input along our process. And that process looked like this. It took place over a 10-month time frame. We recruited 12 individuals, and we consistently had about 7 of them engage with us on average. Sometimes it was different individuals. They weren't, if they missed more than twice, they were asked to nominate a replacement for them or to drop participation. But we were able to keep that up to at least 6, and most of the time more than that, stakeholders at every session. And then we had 2 to 4 of our research team at every session, which were 2 hours in length. We had 8 panel sessions, so we had 2 for every WISE practice. The first session for our practice was to rate all of the priorities of the barriers and facilitators that we had collected. And we did these through interactive processes like card sorting activities and other types of liberating structures. And then our team, we went back, we took the priorities that they gave us, and we mapped these to potential strategies, akin to how you might do in an intervention mapping kind of exercise. We brought those back in a second panel session to the stakeholders where they voted on which ones they thought were important and feasible. And then as a final step, we would bring them draft materials which they would react to and provide us feedback for. So this provides an example of what that process for rating importance and feasibility looked like with our stakeholders. So they rated importance on a 10-point scale as well as feasibility. So the ones that were highly important and highly feasible were said to be in the go zone, or the green that you can see there. And so this one was educational materials, ongoing trainings, and incentives. They rated those things as most important to them. And we did this plotting process in real time with the educators present. So they did their ratings on iPads. We had a Shiny app online that was processing the data. And then we were able to project this image in, again, real time with the stakeholders and discuss their ratings with them. Why did you rate this one highly or this one lowly? Can we talk through this? So that was a really useful exercise. These days in implementation science, we're hearing a ton about mechanisms. And so we wanted to talk a little bit about some of the ways we address mechanisms in our work. This table illustrates how we mapped barriers on to the strategies that were selected, to the mechanism we hope to leverage, and then the implementation outcome in turn that we hope to improve. So for example, with that lack of leadership support, the strategies that they selected to address that were onboarding meetings with the leadership, signed commitment agreements, and then also implementation blueprints that we discussed with them in the onboarding meetings and then left with them. Our hypothesis is that this will increase leadership buy-in and support, and also the norms and expectations that they're setting for their staff. So we'll be measuring feasibility and sustainability, as well as other outcomes that we'll talk more about. But I wanted to also show you how we're doing that with the measures that we've selected and the theoretical constructs from our Paris that it maps onto. So this was the result of all of that process. And it is a two-tier kind of way of approaching this. So everybody gets all of this. So I want to be clear that no, not some sites get fixed and some sites get tailored. In our trial, if you're an enhanced site, you're getting fixed and tailored support. It simply means that every site, every classroom in the same way got what is fixed. So every leader got a commitment form and a blueprint. Every teacher got a placemat reminder with the WISE evidence-based practices on it. Every site gets a champion that is trained who has a lot of contact with an external facilitator to try to troubleshoot and support as they are working through WISE implementation. What's tailored is what's delivered to individual teachers. And this is based on their fidelity data. So we're going out on a quarterly schedule to observe in the classrooms, and teachers that are doing well are getting incentives. When they're achieving fidelity on our evidence-based practices, they get that incentive. But when they're struggling, they're getting additional resources. Educational videos, or handouts rather, at first, and if they still struggle, then they get demonstration videos. So all in all, this includes 7 discrete implementation strategies that we arrived at for our multifaceted strategy to test. So how is our trial going? Well, we're almost done. This was the plan for our trial. So if you go and look at our protocol, I should have put the reference there, but it is published in Implementation Science. This is the figure that you would see. We plan to have 20 classrooms in each condition. We ended up, because of enrollment, only getting 18 in each condition, but it's matched across the basic implementation and the enhanced. As I mentioned, the basic implementation is pretty standard for the field. It's a 6-hour training, and then they get bi-monthly newsletter reminders. Across both groups, we're monitoring implementation outcomes as well as child outcomes. So FFQ is a parent-provided food frequency questionnaire. We have body mass index, and then we're also collecting resonance Raman spectroscopy hand scans. So this is a carotenoid intake reading that we get by a laser reading on the palm of the children. You might be thinking, as you looked at our strategy, that it seems pretty resource intensive. So I wanted to provide you with some data on that. So far, we have delivered 46 handouts, 33 videos, and 48 incentives. And we are nearly done with facilitation. As you know, in a childcare setting, late April, the school year is really ramping down. So we're very, very near the end. So these numbers won't shift a lot between now and the end of the trial. The most common video that we have delivered is feeding practices, which suggests that's one that folks have a little harder time getting up to speed on. And the most common handout that we have delivered was on providing that hands-on exposure to children. We have logged 124 facilitation activities, and we log these with an app that we've developed for our cell phones. And I wanted to just show you the kinds of things that we're doing when we're logging our activities. Most of our work is in actual in-person visits, and that's followed closely by a mix of emails, phone calls, and prep time. Now, that app that I mentioned to you has been really nice because it allows us to track our start and end time as well as our travel time. And so we're able to look at the kinds of investments that we have in each activity and in each classroom. And so far this year, we've provided 53 hours of support. So across our enhanced treatment classrooms, that's about 3 hours of support. And we are all in the same county as the sites that we're implementing this school year. And that is leaving us at about 19 hours of travel, or about 1 per each enhanced classroom. We also log the types of activities that we do when we go out. And the most prominent so far has been stakeholder engagement and education provision. So there's a lot of numbers here, so we'll walk through it together. And I want to draw your eye to the bottom line. Now, I mentioned before that a failure is someone who's not able to get a score of 2 on our scale of 0 to 4. So they're really doing poorly on our fidelity measures. But at that bottom line, no practices, you'll note that the treatment group at the end of our second quarter was doing 5.5% better. I'm not making claims about any statistical significance, but we're just seeing kind of where we are at the middle of our year. And then another number that I'm really drawn to is that line of 3 practices. At the end of the second quarter, which is at the end of February, our control group was failing to meet 3 practices, about 40% of the teachers. But in our treatment condition, that was only about 11% of the teachers. You're probably also noticing that there are the same number of teachers in both groups that are failing at all of it. And I want to speak to that a little bit because I think that relates to something that we're finding as we go along here, which is there are different types of responses to implementation in these childcare settings. And that's what I want to dig into a little bit here. So as I was coming new to this thinking about and measuring fidelity, I really hadn't in my brain come to understand that there's a lot of variation within non-responders or those with poor fidelity. And I want to talk a bit about that. So of course we hope that everybody that responds to our innovations are enthusiastic adopters. They like your program and they do it with fidelity. In our case, that was about 35% of our participants as we ended quarter 1. But what we found is that there were a lot of other types of variation within the folks that weren't achieving fidelity. And we learned this through a couple of ways. First, we did interviews with 5 non-responders at the end of quarter 1 and quarter 2. And then second, our facilitators are going out and seeing lessons sometimes in these classrooms that are not responding. And so what I found is, I'm going in expecting a cross-armed teacher that really is a little bit angry that she's being asked to add something extra to her day, and that's not always what I found. In fact, in 24% of the cases, we saw what I'm calling over-adapting adopters. And so these folks would tell me that they loved the program, they loved the puppet, they had nothing but glowing things to say, great attitudes, but they had made fidelity inconsistent adaptations. And I'll give examples of those shortly. Our soft and hard resistors didn't have great attitudes, but they were different in some important ways. Soft resistors had poor to moderate fidelity, and they had lack of interest in general. Not just very interested in taking on anything new, passive, not so engaged when you would go to their classrooms. And this was about 17% at the end of that first quarter. But our hard resistors were vocal. They had complaints. They were telling their colleagues about their complaints, and they had pretty poor fidelity. One of these individuals told me that they had been teaching for 30 years and I had better get out of the way. And I can understand that. They have a lot on their plates as teachers, but it is interesting to think about the differences in the kinds of responses that we get from them. So I wanted to share this example of a fidelity inconsistent adaptation. And this is a quote from one of our non-responder interviews. And she said, "That puppet really works. That's why I don't bring her out right at the beginning. I sit here just to see who's going to start. One little boy don't hardly want to taste nothing. But when I get it, the puppet, they'll go ahead. Just to make sure we get everybody into it, we're going to use Wendy." Now, Wendy is intended to be brought out from the front of the activity to generate enthusiasm from the get-go, to be a positive cheerleader. But as this quote alluded to, and as I have seen in many of our classrooms, Wendy can become a tool to pressure children, to even in some cases, shame children. And while I hate to end on a negative note, this is the reality of the work that we do in implementation, and it's been wonderful to learn as we've gone along. I want to just acknowledge that I have a wonderful team of individuals that I work with. A lot of this work is on a career development award funded by the NIH, and so I have wonderful mentors and advisors that work with me through that. I also have an excellent team who contribute in such rich ways that I couldn't do without. Our stakeholders have been invaluable from the get-go of developing WISE to getting to where we are today with understanding its implementation. We also thank our participants and the numerous student interns who have been involved in our project. So I'll say thank you and turn it over to Dr. Yoong.
Thank you so much, Taren. And now we're gonna transition over to Dr. Yoong. And I've noticed a couple questions come in while we're switching over. So if you have other questions, please feel free to type those in the box, and we'll go through the question and answer at the end of the presentations.
Is that coming up okay, Rachel?
Yep, we can see and hear you now. I mean, your slides now.
Great. Thanks for that, Taren. That was really interesting. So as Rachel said, I'm Serene, and I'm from the University of Newcastle, Australia. And we've been working to improve nutrition guideline implementation in childcare centres for the past couple of years. Before I start, I'd just like to acknowledge that a lot of this program of work was undertaken by my PhD student, Kirsty Seward, and some of my colleagues, Megan Finch and Alice Grady in particular. And I also like to acknowledge my funding body, the Australian Research Council, for providing me with salary support to do some of this work. So I'll just speed through the next slide. I'm sure none of us need convincing that dietary risk factors are an issue internationally and a leading cause of death and disability. And we know that population-wide, both adults and children find it hard to meet dietary guidelines. And early childhood is an important period to improve diet, both short-term and long-term, because there's lots of studies documenting the tracking of dietary behaviors from as young as 4 or 5 into adolescence and into adulthood. And as such, it represents a promising strategy to reduce the burden from dietary related diseases. And childcare centres are a recommended setting to implement nutrition programs because of the broad reach they provide to young children. And in particular, childcare services in the majority of developed countries are required to provide foods consistent with national dietary guidelines to support the consumption of healthier foods while they're in care. So despite such recommendations, there's international literature that documents only between 10 to 30% of childcare services are able to meet their sector-specific guidelines in terms of food provision. Locally, our research in one state in Australia, New South Wales, found that no centres were able to provide sufficient serves of vegetables and meats on their menu. And we actually know very little about how to best support childcare centres implement this guideline. So a Cochrane review we undertook in 2016 found that there were very few controlled trials that had examined this, and of those that had, there was limited evidence in terms of what worked the best. And so the broad aims of this program of research was to really help increase our understanding of the types of barriers and enablers to implementing dietary guidelines in childcare centres. So we were interested at looking at it in childcare centres that were responsible for providing food to children. So in Australia broadly, there are two types of childcare centres. One where parents pack lunch boxes, and the other where the childcare centres are responsible for providing food. So in these services, we really wanted to understand what difficulties they had to implementing dietary guidelines. We also wanted to use that information, similar to, I guess, what Taren said, to design effective interventions to improve implementation and also to evaluate them. And lastly, we wanted to design an intervention that was scalable and could be implemented to large numbers of childcare services. So we used this four-step process that has been outlined by French in his paper, and we used it to guide this program of research. So the 4 steps consist of who needs to do what differently, and then step 2, using a framework, assessing the barriers and enablers. Step 3 and step 4, looking for potentially effective intervention components, and then measuring the change. And so I'll step through the steps in the next couple of slides. So for step 1, who needs to do what differently? I guess for this step, we really just wanted to get an understanding of what was happening in the childcare service on a day-to-day basis, just when they were operating regularly. So we set up some observations of 4 childcare services that were known to us. We came in and we tried to be as covert as possible and just watch the food service and food preparation processes. We also did some semi-structured interviews guided by the theoretical domains framework. So I'll talk a little bit more about that in the next slide, but that's basically our theoretical framework that we use to guide the assessment of barriers and enablers. And we also reviewed current menus, procedures, and operations of the services. And what we found, I guess it's not surprising, but it was fairly, at that point in time, it was a little bit unexpected for us. So most of the time, centers were really unaware of whether their menus were compliant or not. They were trying their best, and they just didn't know most of the time. And there also seemed to be less of a food service preparation need and more of they needed time to actually sit down and properly review and plan their menus. And once a menu was in place, it seemed like they were able to do the rest fairly consistently. And also lastly, that cooks needed to be involved in the menu planning and reviewing process, not just the purchasing or the cooking process, and that they really were after being part of the entire process and wanted to have a little bit more autonomy to provide healthier foods supported by the service. And taking this in mind, we set up to identify some barriers and enablers to the service to planning a menu that's consistent with dietary guidelines. So we use the theoretical domains framework, which is an integrative theoretical framework which incorporates 33 theories of behavior change. And the framework is meant to be fairly comprehensive and covers a broad range of health behavior change domains. So there's 14 domains, and it covers things like knowledge and skills and social professional role, beliefs about capabilities, and so on. So all factors related to provider implementation of guidelines. The process we took to identify barriers and enablers included looking to the literature. So we did a systematic review of barriers and enablers and grouped them according to the TDF. We did a quantitative survey with over 100 services in New South Wales using an adapted TDF tool, and we supplemented it with semi-structured interviews in step, as described in step 1. So I'll just go through what we found quickly. So they were a combination of findings from the interviews, the qualitative interviews, the quantitative survey, and the systematic review. The main barriers relate to, I guess, social influences, so lack of support. Cooks felt a lack of support from supervisors, parents, other staff to be involved in the menu planning process and to make any healthier changes to the menu. They also spoke about not having enough tools and recipes to support them. And there was a general barrier around knowledge and skills where they were not familiar with the guidelines, and they also lacked confidence in their ability to self-assess whether they met guidelines or not, and they didn't know if foods were, I guess, healthy or not healthy. And lastly, they thought that making any healthier changes might increase food budget, increase the wastage, and reduce acceptability to the types of food that they were serving. So the enablers, I guess, were broadly grouped in similar domains as well. So having more support from their managers and other educators, the provision of more resources, recipes that were healthy, sample menus, policies to facilitate this. They were very interested in skill building type activities, so training and support to plan menus and interpret guidelines. And they also thought if they got more reinforcement and feedback about changes, they would feel more supported to implement guidelines. And so using this information, we set out to test the effectiveness of 2 implementation interventions of various intensities to see its impact on food provision in childcare. We did a 3-arm randomized control trial, included services that were open for 8 or more hours a day. They provided all foods on site. They had a service cook, and they did all their menu planning on site. Included 75 long daycare services, so there are services who are open for 8 or more hours in the Hunter New England region. And we randomized them to a low intensity intervention, which consisted of just training and one-off menu review and feedback, to a high intensity intervention where they got a bit more, and to a usual care control arm where they get support in response, support from their health promotion team in the region, just in response to any active requests. And we looked at how well their menu complied with guidelines as assessed by blinded dietitians. And we did an intention to treat analysis and logistic regression controlling for baseline. So this, I guess, is step 3 of the Fourstep process, trying to map implementation strategies to identify barriers. So broadly, the strategies had to have some evidence of effectiveness either in the childcare or other settings, and they had to be acceptable to childcare center staff. So we ended up, I guess, with a low intensity intervention that we thought targeted a broad range of barriers. So that largely included, as I said, a training workshop, menu review feedback, and some provision of resources, and a high intensity strategy that was similar but included more tailored ongoing face-to-face support, as well as really quite active processes to seek supervisor and other staff member support of the cook, and all of that were tailored to the services needs. So it ended up being an intervention that was quite heavily reliant on face-to-face support by dietitian. So this, we found at 6 months follow-up, so the high intensity intervention, there are improved the provision of a number of food groups consistent with guidelines, and there is no change observed in the low intensity intervention. And so we concluded that a high intensity intervention was needed to support childcare staff with implementing dietary guidelines. But the next thing we were actually really interested in doing was to make this intervention available more broadly, not just within our local services. So we were really asking the question about whether the high intensity intervention could be scaled up to other childcare services beyond our area. And to answer that question, we did a broad scalability assessment using some of the questions proposed by Andrew Murat. And while the intervention was effective, our services were largely located in urban areas. The cost of delivery was high. We suspected, even though we didn't formally assess it in the cost effectiveness analysis, the reach and adoption could potentially be limited due to its reliance on face-to-face support. We thought that broadly the importance of implementing dietary guidelines aligned with New South Wales priorities at the time, as well as the service delivery context. And in terms of acceptability, it was highly acceptable to childcare services, but because of the costs, it would likely be prohibitive for health services and policymakers. And so we set up to, I guess, modify the high intensity strategy to be primarily delivered via web, in an attempt to reduce its costs, reduce its reliance on face-to-face support, and to increase the reach of the intervention. So some components were kept in the online program, as well as we kept the 3-hour face-to-face training because that seemed to be really quite a critical component in both arms. We tried to do all menu review and feedback via the online program. So we tried to provide all support via an online help desk or telephone if needed. Provided all resources online. Tried to facilitate executive support at the training session and generate goals there. There was a parent portal that linked changes to menus to parents so that they could provide reinforcing feedback to childcare services. It was also linked to a reporting platform, so services had to log in daily to report on attendance, and at the same time they could access the online program. And we put up a range of videos and supporting online resources into the program. And so we have just wrapped up this the evaluation of this trial. Broadly, the methods are very similar to the other trial, but this is the 2-arm one. We ran a 12-month intervention with 54 long day care services in all of the states. And we looked at menu compliance again. We also assessed child consumption by dietary observations, and this time we bedded in cost effectiveness analysis as well. So the protocol for this has been published, and we've just finished all the analysis of the data. So I believe a colleague of mine is presenting this at Prague, so watch this space. And I'll just quickly show you what the online tool looks like. Some recipes, the parent portal, just the audit and feedback, and some suggestions for modifying their menu to meet the recommended serves. So I just wanted to acknowledge the big team behind all of this work at Hunter New England Population Health and the University of Newcastle, as well as the various pots of funding to fund various components of the research program, and Healthy Australia in particular for developing the online program, as well as our participating childcare centres and cooks, children and parents. That's it for me.
So it looks like Rachel's muted.
Hey, Rachel, I think you're muted.
While she's working on that, I noticed there was a couple of questions in the chat box. Which,
Thank you. Sorry.
Okay, there you go.
Would not, despite clicking and clicking the unmute button, it would not unmute my computer. I'm happy actually if you want to read the question in the chat box, Q&A box, I'm sorry, that are directed at you, or I can read those. Either way, it looks like there's 3 questions that were directly related to Taren's presentation, but if you want to post questions for Serene's as well, that is open also.
Yeah, I'm glad to go ahead and jump in with those while folks are typing in their questions to Dr. Yoong. So the first question was about the barrier of food insecurity. She mentioned that she saw it on a slide, but I didn't have time to go into it, which is absolutely true. She says, in EC services or family-based food insecurity, how do the teachers see that WISE is helpful and or problematic? So this was a specific barrier to the evidence-based practices of positive feeding. So pressure to eat is one that's really big. When we ask teachers what makes it tempting to pressure a child, a lot of times this answer around food insecurity comes up. Either they're experiencing it themselves, and in our state-based data, we find that about 40% of providers do, or they have concerns, or they have concerns that the children they're serving are food insecure, because most of our work is in Head Start settings, which is a federally funded program that is targeted at serving families impacted by poverty. So they have this driving concern that they want children to eat enough while they're with them, and they feel like it's the healthiest, most wholesome food they could be exposed to. So please, please eat. Kids, eat, clean your plate, try another bite, take it. And so we really have a lot of issues with that. I have a publication on that I'm going to respond to in the chat box with that citation to you. And I don't know if that means others can see it or not, but maybe they can. The next question was from Allison Spence, and she asked, could you comment on the evidence base for the Mascot and why this is as important as positive feeding practices or role modeling, especially if it might have been unintentionally used as a pressuring tool, which is an excellent question. So first, I'm going to also respond to her question with a couple of citations. One is our protocol paper, which we provide the evidence base for each and every of our practices of WISE, which includes evidence from systematic reviews, quasi-experimental designs, as well as randomized trials. So I'll put that citation for the protocol there, as well as our recent paper about WISE outcomes. So why do we think it's so important? We have a paper that we're working on. It's in preparation, and we have presented this as an abstract, so I don't feel terrible spilling some of the results. So it told us that children who go home, this is based on parent report, but children that go home talking about the puppet are the ones whose parents are most likely to make changes. So they had greater at-home dietary changes if they come home talking more and more about Wendy Wise. So it's in the field talked about as pester power. And so we have that paper that'll be forthcoming. But the relative importance of the components, which I think is your key question, is an empirical research question that we haven't tackled yet. So is the mascot more or less important than role modeling comparatively? And I don't know the answer to that yet. It is something that I'm interested in addressing later on. So I'll put those citations there now, and if either of you have follow-up questions, I'd be happy to answer those.
Great, thank you. So we have a couple of questions over here, if you don't mind. We're wondering, thinking about the sort of both categories, the fixed and tailored strategies that you described. So thinking like the next step, if this were to be, go beyond a research study, who, first of all, how intensive or sort of what's involved in that fixed versus the tailored, and then who might be able to do those fixed and tailored strategies?
Yeah, that's a great question. So fixed is pretty low intensity. It is, the facilitators did the onboarding meeting with directors, which is about an hour. We've already made the implementation blueprint, so the resources expended there are already expended. The placemat is created, and it costs less than $5 to make, but it is a nice placemat. They can also use it as a cutting board for the food experiences. And then the champion training is 2 hours in length. It's been developed, so it takes the time of a facilitator or trainer to deliver that. And then if we only had facilitated through the champions, which I didn't mention, but that was our original plan. We were only going to talk to champions, the facilitators. But it ended up that we needed to iterate that plan a little bit. And so the facilitator contacts got more intense than that and started swinging toward the tailored side. So I would say, who can deliver? We have a variety of expertise and experience on our team. So there's myself, who operates the PI, more of an implementation scientist, and background in nutrition and childcare. I was a childcare provider. And then we also have individuals that have been through the training. So we base our facilitation process on the VA's manual for implementation facilitation. We've all been through that training. And so those individuals have different kinds of background. One of them has educational background, was a classroom teacher, and the other has more of a business actually background, but really connects in the community well, and also is interested in community partnerships. So she's really come on with that. So did I get your answer to both parts of that question, Rachel?
Yeah, I think so. And I was just sort of thinking if this could be sort of turned over to a system, that might be able to, be delivered outside of research, if that's an option.
Oh, right. Yeah, I think in the future, we have plans to test the difference between the fixed strategy delivered on its own, which probably could be translated outside of a research setting, and then the fixed plus tailored. What additional impact do you get, and is it cost effective? Because you saw how much it costs, or not how much it costs, but you saw the resources that we're pouring into that tailored level of implementation support. So we would kind of get a value statement about that. And then I guess in theory, we could develop a training, like a train the trainer model, to provide that support if it was going to go outside research. That's a good idea.
Great. No, that's really helpful. Thank you. I don't see other questions in the Q&A, but feel free to post them. Until I see one, I'm going to keep asking questions, if that's okay. So I did want to ask, first, Serene, the process that you went through of mapping your barriers and facilitators with the implementation strategies, I'm curious how you went about doing that, if that was a process, who was involved in that, and how you sort of made some of those choices.
Yep, thanks, Rachel. So I guess you were learning as we kind of went along, but there were certainly a number of criteria that we tried to apply. So first of all, they had to have some evidence of effectiveness, whether in childcare or kind of other parallel settings. So it could be schools or perhaps even clinical at that point in time. And they had to be acceptable to childcare service providers. And they also had to be feasible to be delivered from a health promotion perspective. So the people that were involved were largely health promotion practitioners that would deliver the support. We tested some of the strategies with childcare providers. There was, I guess, implementation researchers on the team as well as behavioral researchers more broadly. And we also consulted with health service directors just to get a sense of cost and possibility of it being adopted into usual care if we showed some evidence of effect. So obviously the high intensity intervention still ended up being too costly because of how responsive childcare services were. So we were responding to a lot of additional queries, and we're providing a lot of additional support in response to an expressed need. But we did try to consider that range of factors in terms of selecting and mapping.
That's great. No, it's interesting because you know, this new, as Taren was sort of saying, this new method of mapping, you know, various facilitator strategies, mechanisms, sort of this approach to systematically thinking through some of these. It's interesting to hear different people in their process on how to do those. So
yeah, and I think that like the lacking thing probably, we did try and think of mechanisms, but we were probably less informed than we are now. So the actual planning of a mechanism analysis fell through. That would have really guided, I guess, the adaptation of this program into a web module. So with the second phase of testing, we were a lot more intentional with kind of causal models and trying to specify things and making sure we had the right sample sizes, because it's hard to get the numbers for a mechanism analysis when you're examining settings, changes at a setting level. So just trying to balance all of that stuff, trying to work out what's most important to measure without overburdening our childcare providers.
Yeah, absolutely. And especially, you know, anytime we're doing studies that are at a cluster, you know, a setting or cluster level, it really makes it hard to get enough to do anything. So that's really interesting. I'm thinking about the two presentations next to each other, and sort of one dealing with the food that's available in the setting, and the other dealing with sort of how the food is fed to kids. And I'm, you know, it makes me think, it almost seems like a site would need both. And you know, obviously the childcare system is a little bit different in each country, but I don't know how to think about whether there's a way to merge these things, or what sort of could be next steps that could bring these together for facilities and for providers. I don't know if either one of you.
Yeah, that's a really good segue. So I think a member of our team, Alice, I think she might even be online. She's trying to put all of this together, so targeting food provision as well as some of the role modeling practices that Taren talked about. I think she might have been in touch with you too, Taren, just to kind of try and tie the various bits together. So that's a lovely segue, Rachel.
I think you're definitely onto something, because we see a lot of challenges that with the menus in the childcare centers in which we are in, because the food experience money, or the food experiences rather, may or may not come through a snack, and if they do, that's great, but sometimes they're fed alongside what would be their typical snack. So I was at a food experience last week as an example, and the WISE food experience that was supposed to be served as a snack was a beautiful spinach, banana, pineapple smoothie. And they also chose to serve it alongside what their normal snack would have been if WISE wasn't at their site, and that was graham cookies. And so the children were dipping those cookies in the spinach smoothies, which was really interesting. Yeah, so you're really onto something.
That's great. I'm imagining this very, you know, in a class of, so just, I'm sorry, because so much of this is provider behavior in the modeling, was it a provider that did that first or the kids?
The kids did that. The provider did at that lesson role model as intended, and she was doing quite well. The kids came up with that one. But the teacher didn't have cookies. The teacher wasn't eating the childcare lunch or snacks. So there you go.
So many challenges and so
many, yes.
I don't see other questions coming in. I don't know if there's other discussion points we want to go through.
Oh, Rachel, you had, I'll say this and then we can see if others pop up and then go maybe, but you had emailed last night to make sure we got time to talk about the adopter resistor stuff. So I'm interested if Dr. Yoong has come across any of these variations and types of response in her work, or maybe if you have, Rachel. It's a kind of thing that we're starting to explore more, and I haven't seen a ton of it in the literature, but I'm interested in what other people are thinking about it.
Yeah, I really think it's interesting. You know, we're early in our study, and I wonder how much, maybe this is the intervention is too different, but I wonder if you notice any of these things change about a person as they learn more about the intervention and learn and are trained in it, where they may start off kind of like, don't tell me how to feed kids, I have been doing this my whole life, to where they might say, oh, these are actually pretty useful ideas. It's not that different than what I thought, but this seems like it would be good. So I don't know how you see it happen there too, as sort of how this evolves for a provider.
Yeah, we shifted our facilitation approach after we came up with these categorizations, and in response to that, we feel like we've seen some shifts in the categories. So well, hopefully these results are submitted for presentation at CERT, and hopefully we can spend more time on it there. But we're interested to see, and we are going to recategorize after quarter 2 and 3 to see if there are shifts, because those initial categorizations I just presented were after the first quarter. And we think that, for example, we may have gotten some people to move from hard resistor to soft, which is a win, if they can just stop being vocal about how much they don't like the thing. And then conversely, we've seen some people fall off. They got tired, and so they were moving from more of an over adapter to now a soft resistor. So there is movement among the categories. I think that's important. But it also just helped me, I don't know, it helped me make sense of things. So Dr. Yoong, are you seeing anything like that?
So I thought that was kind of really interesting and such a clever way of grouping things. So definitely anecdotally, we've seen people who seem to say yes to everything, like the over-adapter group I find particularly, because you think, oh, they're on board, you're just going to do it all, and this is amazing, and you go back in and maybe like 10% of things get done, and just do enthusiasm. So I definitely kind of find that description as you're talking through the 4 quadrants, really, because we tend to think of people as like delivering it and not, so we might just look at the hard resistors and the ones that are just fully compliant, and the strategies, we put in place strategies for both. But I guess the softer groups, which are the soft resistors and the over adapters, we might not have as many strategies in place to cope with them, because they're probably not overt in their dissatisfaction, or they think, oh, I'll just take it and I'll do it as I wish. I'll take the components that I want and I'll do it. So that's certainly been kind of anecdotally we've experienced, and I think it will change the way we think about our strategies too. As you were talking, I thought, oh, we really need to have kind of more resources up our sleeves in terms of maybe targeting the unspoken, the groups that are not as vocal, I guess.
Right.
Did you find that anything worked better?
Well, for our hard resistors, we shifted our facilitation to just getting them to like us. So we're going in and we're finding something positive to really encourage and develop in that provider. We're not providing many suggestions or critiques. We're just high-fiving, way to go, this is great, tell me about your grandkids, you know, really working to develop a relationship with those individuals more than anything. And that seems to have been effective. We'll have data on that soon, but what we're seeing in the field is they're less likely now to kind of spread negativity in their context.
Yeah.
You know, I'm thinking, and I'm trying to frantically look it up while we're talking, back to sort of the original diffusion of innovations model and how this does or does not map onto that idea so, you know, it's a little different because it's not just the pace of adoption here, it's the attitude towards adoption and implementation and, you know, I think I just made a distinction there. It's the difference. It's not just adoption, but it's also implementation. And so I think that there's probably things to be learned from that, but also something, you know, things that are additional that this is probably uncovering.
I think that's a really interesting parallel that we've thought about too, but I think you're onto the difference because you wouldn't move from being an early adopter in that model to backwards to a laggard. You could never regress that far. But in our model, that would be possible. You could start out really enthusiastic and loving it and just, well, for example, we've had teachers' houses burn down and car wrecks happen, and it's really hard to maintain engagement in a new implementation effort when all that's going on in your personal life. Clay Cook on Twitter yesterday was posting about how stressed adults don't make good implementers. And so it's more than just what's happening with our innovation. It's their context and the context of their personal lives too. So it's complex.
Yeah, it's a really, and it's nice that you're getting to measure this over time because I do wonder when we think about our implementation strategies and we think about, you know, mechanisms we might be targeting, if we're getting people to move in these different directions in terms of their attitudes towards our interventions and also then fidelity with which they do them. Interesting.
Yeah.
Yeah, I'll be interested to see what you find. I don't think this is we're not measuring this in the same way, so I'll be curious a study that does.
Right, and PJ was just piping in on the chat box to tell us that we got it right. It is Rogers' diffusion of innovation, and it talks about early adopters, late adopters, and laggards. If anybody in the audience is interested in pulling that out, it's really useful too.
Interesting. Well, I can leave our questions for another couple of minutes or maybe a minute if anyone wants to put in a last word. I know I learned a lot today. I really appreciate both of your presentations and the discussion. It's really interesting to think about the different opportunities and all the different complexities of feeding kids in childcare. I do want to plug the implementation and scalability meeting at the annual meeting in June in Prague. If anyone knows the time or date of that, I don't. But you can definitely find it on the website in the program. If there aren't any other questions, thank you everyone for joining and participating, and I hope you learned as much as I did.
Thanks, everybody.
Okay, guys. Bye-bye.
Bye.